Thank you all so much for coming to be here and joining us for this really exciting and important topic. We have some incredible folks joining us to talk about sexual, reproductive, and maternal health in America. To my left is Dr. Michael Liu, the Dean of the UC Berkeley School of Public Health, and you were formerly Director of the Maternal and Child Health Bureau at HHS. So a lot of different perspectives to share with us. Christy Turlington-Burns is the founder of Every Mother Counts, and she's produced 5 films on pregnancy and childbirth and has another one coming out on Native mothers pretty soon. Dr. Lena Wen is a visiting professor of health policy and management at the Milken School of Public Health at George Washington University, former president and CEO of Planned Parenthood, and the former commissioner of public health in Baltimore, where we got to do a story together on naloxone and the opioid crisis. And of course, Representative Lauren Underwood from Illinois, who is the co-chair of the Black Maternal Health Caucus, which she co-founded this year. Yes. So. A lot to discuss. I'm going to start by asking Christy to tell us about your personal experience that got you into this space.
Sure. So I became a global maternal health advocate the day I became a mother, which is almost exactly 16 years ago last week. My daughter just celebrated. And after a great pregnancy and wonderful options to a lot of choices around my pregnancy and healthcare, I had an unexpected postpartum complication, which resulted in a hemorrhage after she was delivered. And while I was in a place where I had the right care and a team that worked really beautifully together to make sure that our needs were met and that we were healthy throughout the process, I was really shocked to learn soon afterwards that hundreds of thousands of girls and women around the world were dying from pregnancy and childbirth-related complications similar to the one that I had endured, but also a variety of others. And to think that in the 21st century, so many women were still suffering and dying needlessly just really shocked me and surprised me, and once I learned the facts, I couldn't forget them. So I dove in and have found a way to be a very active advocate. I started a documentary film called No Woman, No Cry that came out about 10 years ago, and then started the organization Every Mother Counts to engage the public and invest in some proven models of care around the world that are addressing access to quality maternity care.
And I think that really speaks to just how little we really know about this until we have an experience like this ourselves. Can I just ask the tech folks if you wouldn't mind starting our countdown clock? And I should also mention that the Congresswoman will need to leave about 10 to 15 minutes before the end of the session. We will start the Q&A a little bit early so that you can ask her some questions before she has to scoot out, but just wanted to tell you all that before we got going. So to kind of broaden out that story that we just heard from Christy, if Dr. Liu, you could kind of help us put some data out there to really just explain the scope of where we are with women's healthcare and the issues that are so much bigger than I think a lot of people realize.
Right. So yeah, first of all, let me just say that here in 21st century America, in the most powerful nation on earth, no woman should ever die from pregnancy and childbirth. And yet, every year, more than 700 women die, and more than 50,000 women suffer a life-threatening complication. And that rate's just been going up over the last 20 years, that you're 50% more likely to die from pregnancy and childbirth than your mother. And I think what's most kind of distressing is the persisting racial, ethnic, socioeconomic, geographic disparities in pregnancy and mortality, such that an African-American woman today is still more than 3 times as likely to die from pregnancy and childbirth as a non-Hispanic white woman.
Mm-hmm. The stats are just astounding. And I wonder if, Congresswoman, you could kind of talk about why you founded the caucus this year, and so what goes into the work that you guys are doing.
Sure. So we knew that Black women are 3 to 4 times more likely to die as a result of childbirth, even when you control for factors like whether or not you had health care, prenatal care, whether or not you delivered in the hospital, your education status, your income, whether or not you had health insurance, right? It's just stagnant. It's been that way for the last 30 plus years, my entire lifetime. I had a personal impact impact when a friend from graduate school died 3 weeks after giving birth to her daughter. She was a CDC PhD epidemiologist, devoted her career to addressing health disparities, and she died as a result of hemorrhage down in Atlanta. And so, I knew that this is something that we needed to make some progress on. This is also an issue where there hasn't been any kind of national report, no Surgeon General's report, no, sweeping federal goal setting. And so we knew that this was something where we could make a difference, harnessing the collective power of the United States Congress. And so a colleague and I, Congresswoman Alma Adams from North Carolina, got together and said we wanted to work on this issue. We gave ourselves a name, the Black Maternal Health Caucus, and we opened it up to our colleagues, thinking that it was just going to be the two of us, to be honest with you. And the day we launched in April.
It takes two to caucus, right?
That's right. And in April this year, we launched with 50 members, including 3 Republicans. This is a bipartisan caucus. We had the House Majority Leader stand with us. We are now up to 86 members. We have had some real legislative wins already in the first 6 months, including in the appropriations process out of the Labor, Health, and Human Services House bill. We have new money to tackle maternal mortality. We have a suite of legislation that's already been introduced talking about extending Medicaid to 12 months postpartum for all women, including perinatal workforce issues, making sure that our data pipelines are more robust, and tracking, making sure that the morbidity and mortality review committees, which got a big win at the end of 2018 with Congresswoman Herrera Butler's legislation, that there's some real, I think, robust standards and funding available to ensure that each state is implementing those committees as intended. And then now we're starting to tackle some gaps, right? So looking at bias, looking at telehealth and telemedicine. We know that there's a lot of stakeholders outside of government who want to partner with us, whether it's private industry. Even places like Uber and Lyft have reached out, and they want to be involved in transporting women to their healthcare services. Every single insurance company, right? Because they are touching so many of the women who are delivering. There's a role for everyone to play. We've also heard from the Surgeon General. Trump's Health and Human Services Secretary Azar, wants to work together, right? So this is an opportunity to make real change in a space that had been overlooked for so long. And I'm really excited about what lies ahead.
Dr. Wen, could you give us some of the history? How did we get here? Is it just that it was overlooked, or is there more at play that led us to the situation where we are?
Yeah, I mean, it's a great question. And I just first want to say how thrilled I am that we are making progress and substantial progress in this area finally.
Yes.
Right? And I think you're illustrating that we can't let perfect be the enemy of the good, that there is something that we can do right now, and with the momentum that we have, let's do something. I do think it needs to be said that there's something specific about women's health. I mean, we don't have a conversation about men's health being a state of emergency or men's health being politicized. But there is something about women's health that over time somehow has become politicized, stigmatized, siloed, and attacked, and basically treated differently than other aspects of healthcare. And it's women's health, but more specifically, women's sexual and reproductive health, which cannot be separated from the rest of healthcare. I mean, I know this as a physician, right? You don't separate a part of your body from everything else. But also that has a lot to do with how we got to where we are, with the maternal health issues as they are in this country, with the vast disparities. And I think there's a lot that we can do to look for points of agreement, which is also why I'm so glad that we're having this conversation here at the Milken Institute at the summit today, that there's a lot, I think different sides may disagree on some issues, but I hope that we can come together on certain other issues that will get us to a better place. For example, can we agree that maternal mortality is unacceptably high, to Michael's point, that this should not be occurring in this country right now? Can we agree on that? And then can we also agree that it's important for us to care for women throughout their lives, before, during, and after pregnancy, and that reproductive health care is a critical part of healthcare? And then the third is, can we agree on prevention? That prevention is the best medicine. And can we focus on policies that get us there? And perhaps by looking at this from a holistic lens, maybe that's how we'll get to a place where we're no longer discussing women's healthcare differently than any other aspect of healthcare.
And I wonder also if we can get into some of the details about why mortality is so high. I mean, what is actually killing people as they're giving birth, or before birth, or after birth? Dr. Liu?
Sure. No, I think just kind of looking at it clinically, we know some of the leading causes of maternal deaths include cardiovascular diseases, as well as like the classic HIT triad, which is hemorrhage, infection, and what we call toxemia. Used to call toxemia, but now called preeclampsia. These usually account for about half to 3/4 of all maternal deaths in this country. Now, certainly, these are the kind of what drives the final outcomes. But then there are all kind of these other kind of important social factors, including kind of access to healthcare, not only during pregnancy, but before, between pregnancy and across the life course, that may be kind of driving these tragic outcomes.
So there's a lot obviously contributing to this, and I think, Christy, some of the things that you've explored in your films are a number of things. One is that I think you've made the point that women aren't listened to. You've also made the point that we need to start earlier when we think about this kind of care for women younger. Maybe you can go into those details.
Yeah, we've done a lot of, we've participated in a lot of research asking women what they want. Globally and nationally, as well as just like there's a series called, or there's a report called Listening to Mothers. And more we're hearing women say, I knew something was wrong, I said something, and I wasn't listened to, I wasn't heard. And to have a woman die because of that, or while she knows something is wrong, is wrong. One of the other issues that I think we haven't mentioned, in addition to implicit bias and racism, which is very much what is rising to the surface in terms of these conversations from women, is over-medicalization, right? We have a scenario here where it's too much too soon and too little too late. So we have more interventions before they're actually necessary. When a woman has a C-section that is not an absolutely necessary C-section, she is set up for subsequent C-sections, and that is leading to placenta accretas, which is now, you're hearing more and more about accretas today than ever before. In which case, there's only so many providers that are trained to address accretas. So access to the right level of facility is also a really important aspect of this issue as we start to raise awareness about what the causes are and who's most impacted or affected.
In terms of the implicit bias and the racism, with the Black Maternal Health Caucus, what you said at the beginning was just so amazing. There's so much you're doing already. How do you address the racism issue in the medical infrastructure? I mean, that's a huge problem.
Sure. So, there is an opportunity because the federal government is paying for something like 50 to 60% of African American births in this country. And so we can put some sweeteners and incentives around that care and that delivery. And so getting to the implicit bias, I mean, if we want hospitals to be accredited to receive payments from Medicare and Medicaid, we can put some requirements around the training of their providers around implicit bias. We also are involved at the federal level with training and paying for the training of pretty much every single physician in this country, and offering resources to many of the other providers, right? The schools of nursing, some of the classic midwifery programs. We're exploring avenues to support doula care and the like. And so we have the levers to help adjust curricula and make sure that it's inclusive so that every provider who's taking care of a woman is doing so in a way that centers that woman and her family, and that provider is not walking in with any kind of preconditions, certainly biases, but then also actual racism. And a lot of people, I think, are uncomfortable with the idea that racism exists at a level that is so pervasive that in 2019 it is still killing women. And I think that we need to become more comfortable in centering the dialogue around using those words, because those words have meaning and it's really happening.
How effective is that kind of training in medical school? And I'll open this up to everybody to actually addressing that kind of racism. Can you actually reverse that kind of thinking and just that ingrained perspective?
I mean, I think definitely. I think a lot of that training is modeled in settings, and when you have providers who are mindful about respectful care and have that knowledge and have that understanding, and the people around them observe and follow suit, it's incredibly powerful. The films that we've created, the Giving Birth in America series, we're hoping to create curriculum around those as well, because we've found that when you show a film that involves community-based doulas as the centerpiece of the solution in a community, and obstetricians are watching that film, they're seeing a different kind of impact and seeing themselves as team players, really. Because at the end of the day, the people who take care of women's health all should have the same goal in mind, right? Healthy woman, healthy mother, healthy child, healthy family. Like that's the ripple effect of a healthy woman. And so if we can agree that that's what we want as the outcome, we will do anything it takes to get her there. And if that means incorporating implicit bias training, that's the first step that we should be doing, and it should be at every level of education in the health system.
And also recognizing that it's not just providers, right? Providers practice in a healthcare system that practice in communities that are grappling with these issues every day. And we see those on the front page of the news throughout the course of our weeks and lives. But we sometimes think that as soon as you walk into a hospital or a clinic, that somehow they're isolated, these pure, clean places that aren't part of those larger communities, right? So in the same way, the United States is still grappling with the lingering impacts of race and what that means in terms of our society and equality and justice, our healthcare system is going through those same challenges.
Mm-hmm. Dr. Wen, I want to ask you about what you're saying about polarization and the points of similarities that everybody shares, and where you think, or how you think the countries can do on that. You wrote an op-ed in the New York Times after you left Planned Parenthood, essentially saying that was your view, but Planned Parenthood perhaps didn't necessarily share that view. Do you think we're at a time politically where it's possible to do what you're saying, which I think makes a lot of sense to a lot of people?
No, it is hard, right? And I will be the first to say that I don't know that my strategy is the right strategy. I mean, how do any of us know that looking for points of agreement as opposed to fighting the fight of our lives, right? I mean, it's how do we know that that my strategy versus another strategy is the right one? I do understand the perspective of, look, reproductive rights are under attack. Roe could be overturned, and if Roe is overturned, then 1 in 4 women in this country could be living in areas where abortion is outlawed. And we could go back to the time of back alley abortions, which, as an emergency physician, I've had mentors who told me about what it was like to work in the 1960s, when they had entire wards of a hospital filled with young women who were dying of kidney failure and multi-organ failure and sepsis because of this. I mean, I think it needs to be said that we do have a crisis on our hands, and I could see the perspective of let's double down on that fight because those rights are at stake. I think there's another perspective too of the vast majority of the country, as we know from polling, actually agree on a lot of issues. People think that abortion is a morally complex issue. Many people consider themselves to be both pro-life and pro-choice. Maybe they would not have an abortion themselves, but would not want to make the judgment for someone else and say that another woman should be forced to make the same decision as us when we haven't walked in their shoes. I think there are a lot of people who believe in prevention and having access to comprehensive sex education and affordable, accessible birth control, and that the goal should be reducing the need for abortion and empowering women and all people to make the best choices for themselves and their families. So, I come from that viewpoint of, I think there is the majority that we can really capture and say, how do we make progress together? My mentor and hero, Congressman Elijah Cummings, passed away recently, and he always talked about how he is a uniter, a bridge builder, and always aimed for not only common ground, but higher ground. And that the work that we have is not about what we're fighting about, but who we're fighting for. And I think in this case, for me, it's so personal. As a woman, as a mother, I have a 2-year-old and I'm expecting my second in several months. But it's also very personal to me as a physician, serving my patients. And I can picture, I mean, I had actually, you had a previous question that I also wanted to address briefly about what is causing the deaths, right? About a third of deaths during pregnancy actually occurred during labor and delivery. 2/3 occur at other points, including postnatally. And I had a patient, I remember very clearly, who came in weeks after delivery who was wheezing and just wasn't, people thought that she had asthma, but actually she had congestive heart failure. And why did she have congestive heart failure? She had long-standing, undiagnosed, untreated high blood pressure that was exacerbated during pregnancy, which is a stress state physiologically on the body. And what was happening before that? Well, she didn't have health insurance. She couldn't get diagnosis and treatment earlier. I mean, when we look at the state of emergency for pregnant women, actually pregnant women can be seen as a canary in a coal mine. Because it's not just that pregnant women are unhealthy, it's that women are unhealthy. And what we need to be focusing on, and I think what my North Star is, and has always been, is addressing the needs of my patients, and women and children and families.
As we think about the political situation right now, I wonder if, Congresswoman, you could speak to your experience working in Congress and with the caucus. Do you find there is the ability for both sides to come together on this issue of reproductive health, even as there is that specter of abortion access hanging over it, which is so partisan?
Sure. I think that on this issue, there is tremendous opportunity for bipartisan action because we're talking about saving lives and about something so fundamental that a lot of folks had thought we had solved: maternal mortality in our country. And as I talk with my colleagues, they are stunned to know that this extensive disparity exists. And so I think that in the realm of solutions that we are looking to address, probably 90% of them are bipartisan. The ones that are not, at this point in time, are probably related to abortion access and about Medicaid expansion and its connection to the Affordable Care Act, right? The Affordable Care Act remains sort of this interesting issue in Congress right now that I think, people have accepted because it's politically popular among their constituents, but as we think about making adjustments, that becomes a little bit politically toxic for certain folks depending on where they're from and the types of communities that they represent. So we are jumping in, and we're going to explore all avenues, and we invite members, regardless of which party they belong in, to support and co-sponsor the legislation, right? We can lift it up and say this is something that would make an impact. It could save lives. It could help transform our healthcare system in an equitable, just way. And members have the decision about whether or not they want to personally support it.
And how does that affect the ability to get funding? I mean, it seems like there's all these lines connecting things to politically toxic or complicated areas, whereas if you were able to just say, this is for women's reproductive health, to keep women alive through childbirth, people would agree that they should be contributing to it. But when it's in this complicated situation, does that make funding very difficult?
Well, I think that the funding conversation is one that's challenging. I think there's like two parts. One is in this Trump era, right, where having avoiding government shutdowns is just a challenge right now for us, right? The House passed the Labor, Health, and Human Services Appropriation Bill. The Senate has not moved it. I think that they're trying to save that one towards the end, along with the Homeland Security and border wall funding, because that is something that they perceive, they being the Senate Republicans, perceive as like too hot to handle right now. And that's too bad, because they could be the leaders here and create an opportunity for tremendous change. But I want to be specific about what we included in our bill, which I'm so excited about. We have $50 million in new funding to initiate research on maternal mortality and disparities in maternal mortality. $50 million for the first time. And like that's gotten no coverage. And that should not be partisan. right? Because that's needed. But we know that we can do more, we should do more, and we will, but this is just like that first step. So the second thing I'll say is this. We do not have people advocating around this issue en masse, the way that so many others do. And so this is an opportunity where, regardless of partisanship, everybody represents moms. Everybody represents women. And, you know, we're not hearing from our constituents as much about the concerns around these deaths and preventable deaths and the need for continued resources and funding.
And I think we have heard, you know, over the last few years, you hear about different people's experiences, Serena Williams, other folks coming out and talking about postpartum depression. But why do you think it is kind of, and Christy, I'm sort of looking at you as sort of the celebrity on the panel, if you can speak to that we do hear from people individually, but it hasn't gotten this en masse sort of grassroots support that you see for other issues?
I mean, I think it is what was already sort of mentioned in that this information, or we've fallen behind in the last 2 decades, however, that's just becoming known. I mean, really the last 2 years, I would say, there's been this huge change and shift because in part of the ProPublica series, I would like to say that Every Mother Counts played a role in that. Others who have had personal stories or lost members of their families who have started to have a voice. But it takes time. I mean, Serena Williams' story, I mean, I would never wish it on anyone. However, her story came at the absolute perfect time to be a woman who is so celebrated, who is so empowered, who is so strong, who had her own chronic health condition and recognized and knew in her body that something was wrong, asked for what she needed, and then demanded that care. But so many women of color and otherwise do not have that feeling of empowerment in our health institutions and facilities. And so, I mean, honestly, I think it's really helped to elevate. And then the political will from the Black Women's Caucus, I mean, that has been tremendous. And just Black Women's Maternal Health Week, which launched 2 years ago. I mean, Black Moms Matter Alliance. There has been this increase almost overnight in terms of historical significance in history. It's happening. It is going to continue to happen. Michael and I were talking backstage that like this is a moment that we all recognize for people who have been working in this for decades and people who are newer to it. It is a moment in time, and I think for now we just have to all come together and really build and continue the momentum.
What new tools are there, Michael, that you could talk about in terms of technology that could help make this situation better?
Well, before I talk about technology, I do want to call attention to the quality and safety of maternity care, because I think we know enough today to prevent at least half of all maternal deaths, which are completely preventable if we have better quality and safety maternity care. And this is kind of where.
Move ahead, go back to the basics.
Yeah, go back to the basics. Yeah, let's do what we know we're supposed to do, and this is where the safety bundles come in. These are basically best practices, protocols, drills, simulations, everything that you need to have in order to provide safe care to mothers during pregnancy. In my 20 years of practice as an obstetrician, I've seen good practices, I've seen poor practices. I've been scrubbed in cases of massive obstetrical hemorrhage early in my career, where the whole team's like freaking out and attending is just yelling at everybody, and instruments get thrown and lap sponges get lost, and everyone's like flailing around, and in the meantime the woman just keep bleeding so much so that her body starts chewing up all the clotting factors and stuff, so she just cannot stop bleeding, right? But I've also scrubbed in on cases where everybody knows exactly what they're supposed to be doing, right? Someone's calling out the time, someone's counting instruments, someone's getting blood products from the blood bank, and you can reduce so much morbidity if you know what you're doing, but you wouldn't know how to do that if the first time you're doing it is when it's actually happening. And that's where protocols, checklists, drills, simulations, etc., all of those are so important to do. So back in 2005, I joined a network of doctors, nurses, public health professionals in California. We developed these kind of early prototypes of what we call safety bundles, and then we took it around the state. We did in-service training for labor and delivery staff. We did grand rounds. We engaged hospital CEOs in these quality improvement initiatives, and then we watched the needle move in real time. So up until about 2006, California's maternal mortality just kept going up with the rest of the nation. With implementation of these safety bundles, California's maternal mortality decreased by about 60% in 6 years between 2006 and 2012. And that's why we know that there's something we can actually do today that would save a lot of lives. And so when I became the director of the Maternal Child Bureau in 2012, I wanted to just scale up California's experience. So we launched the initiative called Alliance for Innovation in Maternal Health, kind of working with ACOG and about 20 different national public and private partners. And now we're got these safety bundles into more than 1,000 hospitals across kind of over 20 states, with the idea that if we can get these safety bundles into every single hospital in the next few years, we can reduce maternal mortality by half in the next few years. So there's something that we really could do today.
Well, that's such an important point. I'm really glad that you said that. And what are the hurdles to implementing that in all of the hospitals across the country?
Well, initially it was purely kind of funding, and we started with $1 million to try to get these safety bundles into 10 states. And by the time you go to the state and go to all the different hospitals and county and so forth, everybody was doing this out of labor of love, right? Because they really believe in this cause. And again, this is where I just appreciate so much champions out there to really create that political will. And this is kind of really that window of opportunity that we haven't seen in decades. If we don't get this done in this country, that's on all of us. Right, and so again, just appreciate your leadership in Congress, Congressman Underwood, and appreciate all the star power that Christy, you've been bringing to this. And I agree. We've known. I think I read my first paper on maternal mortality, the crisis of maternal mortality in America when I was in medical school. We've been trying to do this for decades now, and we tracked unequal treatment in healthcare settings for over 2 decades, but it took someone like Serena Williams to finally call public attention to it.
I want to open up the technology and the new tools and sort of the futuristic question to everybody in the panel. And while we answer that question, I want everybody to be thinking about any questions you might have, particularly for the Congresswoman who will have to pop out in a few minutes. So new tools, technology, what's exciting? You mentioned Uber and Lyft are interested in getting into the space. Is telemedicine a good answer? Does that help? How do you all look at what technology could bring?
Well, we know that there's many women in this country who lack access to providers, right? So these same access to care barriers that we talk about in other settings certainly apply in the maternity care space. I represent a community in Northern Illinois. I live 45 minutes west of Chicago, but in my district, there is a county that doesn't have a hospital. So you better believe that county that doesn't have a hospital is sort of lagging behind in other providers. And so while I think we do want to embrace some of the opportunities that do come with technology, we also can't ignore and neglect the real work that we have to do in terms of training this next generation of healthcare professional. We know that telemedicine is something that gets a lot of people's ears perked up on Capitol Hill. And why? Because it is cheaper to invest in telemedicine than it is to fund human beings, meaning providers, and train them and see them all the way through their clinical training. It is easier and cheaper to put a television screen and a broadband dial-up in the middle of a rural community than to really tackle the challenges that face rural healthcare providers and to reduce some of those access disparities. And so the challenge that we face is to continue to encourage that innovation to happen, to test whether or not telemedicine is a sufficient intervention to save lives, which I have to tell you, I'm a little bit skeptical of, particularly for Black women. But perhaps the data will show that we're wrong, and I am a data-driven, evidence-based policymaker, and so, hey, I will support where the data leads us. And we know that there are, outside of telemedicine, like apps, really exciting things that help that mother or pregnant woman be able to track, take ownership, troubleshoot, and gives her some resources right on her phone.
And I'm so glad that you talked about the limitations of telemedicine.
Oh, yeah.
I think in our worlds, coming to these conferences, it seems like telemedicine is billed as the panacea.
Yeah.
But coming from Baltimore, coming from the local public health world, I see the opposite. I mean, I see telemedicine as a tool, but it's not the end goal. And actually that there is so much of the face-to-face interaction that's critical. I mean, there's a lot that we can actually be doing now. So, for example, integrating reproductive health care and primary care. A lot of people are beginning to ask the one key question. Primary care doctors and primary care providers are asking the question of women of reproductive age, are you planning to be pregnant in the next year? Just one question. And if the answer is yes, if the answer is no, then it could be a conversation about contraception and what are you using, what else can we offer? If the answer is yes, that could be an ideal time for screening for mental health issues, for addiction, for blood pressure and diabetes and other things that could become real complications that then lead to maternal mortality and ill health. I mean, that's a very simple, low-tech innovation. But having the trusted messenger to do that, having people trained and having access to it, and I think also not just seeing reproductive health care as something separate, but having primary care doctors and providers able to do reproductive care, and at the same time, having reproductive providers also being able to treat other primary care concerns. I mean, this does not require high-tech innovation, but I think is key to bridging that access gap too.
Yeah, I'm going to caveat my response by saying, I don't believe technology is the answer, but certainly I believe technology can help. So for example, if you just kind of take prenatal care today, right? It's not all that different from how I was trained like 30 years ago. Now, some softwares have changed, but the hardware, how we actually deliver prenatal care, is still kind of very much the same, right? And it's still centered around the clinic visit, which is kind of recommended up to like 15 visits for the kind of average American women. Which for low-income women, that means that they have to take time off from work, often unpaid, take several buses, go to the waiting room, wait for an hour or two for that 5 to 10 minute visit, during which you get a spot blood pressure check, a spot urine dip, a quick listen to a baby's heart tone, a quick measurement of the baby's fundal height, and then just this hurried conversation with the provider who neither has the time nor the training to talk about self-care, let alone all the like really important things like environmental and occupational exposures, right? So what if we were able to like bring prenatal care to the 21st century, with wearables and sensors and lab on the chip, instead of like the woman going to prenatal care, can we bring prenatal care to the woman? And can we be collecting high quality continuous data on things that are actually not just gadgety and glitzy, but on things that are actually truly important, like nutrition and physical activities, like stress and sleep, like environmental and occupational exposures. And what if all of these data can be fed to the cloud, and then with AI and machine learning, we can both develop better predictive analytics in terms of identifying which women are at risk, but also better tailor the care to the needs of individual women. So for example, triaging women to, you need a call from the health educator right now, or you need a home visit from a home visiting nurse tonight, or you should come and see a specialist tomorrow. So what if then can bring whole design thinking? So we're kind of designing prenatal care around the need of the woman and family, and not just the convenience or the profit of the health system. So that's where I think that we can leverage science and technology, big data innovations to really improve care and outcomes for women. That said, just a couple quick caveats. First of all, I totally agree that high tech by itself is not enough. You really need to marry high tech with high touch, but sometimes that high tech actually affords you the opportunity for a high touch in things that actually truly matter. Birth education classes, group prenatal care, individual counseling, and so forth, right? You can free up resources for you to be doing kind of things that where high touch is actually really important. And the second thing I always kind of worry about these technological advances is that they don't always guarantee equity. Right? In fact, some of these technological advances can actually widen disparities if there's differential access. So our job is to make sure that as we push for technological advances, to make sure that they are put to use to advance health equity and not widen health disparities.
Just to add to that, I think the implicit bias training has to go into the design of any of these devices, and I don't think that that's happening at the level it should be yet.
And what you were talking about in terms of personal care and as you're going through pregnancy, even just the nutrition and the sleep and the stress and all of that. I had a baby 10 months ago, and I will say, as an extremely privileged person who was in a New York City medical system, I haven't felt like I was part of a factory. I mean, I would go into the labor and delivery or the place where I would get the imaging, and honestly, I was like one of like 20 people sitting in a chair, and the doctor would speak to me for about 5 seconds afterwards and be like, all looks good. I'm like, wait, can you tell me a little bit more? Is it actually, they didn't have time. And I barely knew this doctor, and I knew my own OBGYN, but not the person who was telling me that, my son had something going on or whatever it was. And so if there could be something that would improve that, I think a lot of people would really appreciate it. Questions from the audience? Do I have, hello, over here. Sorry, it's hard to see, so stick your hands up and wave if we don't get you.
So I just wanted to elaborate or provide my real-life example for the training issue that the Congresswoman spoke about. So I'm a clinical psychologist, and in my class, there were 4 people accepted for 300 slots. So we have definitely a pipeline issue, and that there needs to be more funding for these programs that are focused on mental health professionals. I think a related issue may be, why aren't programs able to accept more clinical psychologists? And that may be related to the reimbursement issue for mental health concerns. So I just wanted to bring that real life example of how few people are actually getting trained to make a difference in the mental health space.
Anybody want to address any sort of potential solutions or expound on the problem?
I mean, only to agree with you that this is such an underlooked area, that we treat mental health somehow differently than physical health. And to talk about the huge stigma around mental health too. When after I had my baby, I didn't recognize, nor was I screened for postpartum depression.
Really?
I did not realize.
Every appointment for like 10 months, they give me the same questionnaire.
I think that, so I had a great OB who I have now for my second pregnancy too, but my OB just was like, well, you know what to do. You're a doctor, you're fine. And I think it's an example of bias and, kind of in a different way. But I actually didn't, by the time that I recognized and knew that I needed treatment for postpartum depression, it was 6 months after. And I felt such fear and stigma around it. That's one of the reasons I'm talking about it now. But I think that also speaks to your point of, why don't we have this issue be brought to prominence? It's because of, yes, lack of funding and lack of equitable treatment, but it's also because of the stigma that we have around this issue.
Yeah. Thank you all so much for having me. Thank you for your great work. I'm so honored to be on the stage with you. And continue to follow us at BMH Caucus on Twitter. Thank you.
Thank you.
Pediatricians at the moment are doing a lot more of the checking in with moms about postpartum depression. And it's good because women are incentivized to bring their kids in more so than getting the care themselves sometimes. But it's not enough. The pediatricians and OBs should be working together more closely to be able to, again, share that data and share the information that they're learning on those visits.
I think it's really a kind of big systems kind of design issue. I just kind of remember to think back to my own practice where I was scheduled for prenatal visits about 15 minutes for every woman. But the day of, they often you get the add-ons and so forth. So now you have 7.5 minutes. For each woman, and you're trying to do everything you can, during those 7.5 minutes, and trying to be mindful and everything. And if you screen postpartum depression, now you're stuck, right? Now you got to do all the counseling and so forth, and you're like trying to get her connected with a psychiatrist or psychologist. And the earliest appointment that you can get is in 3 weeks, and then you got to figure out what to do in the meantime to support her and so forth. So the system just isn't currently designed in such a way to really support the needs of women and families. And so that's where I think really thinking in terms of a fundamental transformation of our health systems in such a way that you create teamwork, not just with the obstetricians, but with nutritionists, with mental health care providers, with doulas and midwives, with home visitors, with health educators, and so forth. That's the kind of system that we need to be moving into if we want to provide the kind of comprehensive, holistic care that I think every woman deserves.
Mm-hmm. Other questions? I'm trying to see if oh, okay. Hello.
Hi, I wanted to ask a question about postpartum care. I was really surprised when I had my child last year that my doctor sent me home from the hospital and said, I'll see you in 6 weeks. Meanwhile, my son was going about every 2 days to have care, and 6 weeks was plenty of time for me to develop complications and end up in the hospital, which could have been avoided, I think, had I seen a medical professional. And I just wondered if there's any change coming in that standard of care practice where a woman might be sent back to her doctor a week or 2 weeks after childbirth if we're moving in that direction to hopefully catch some of these problems before they become bigger problems.
Yeah, so the 6-week postpartum visit actually came from a long-held tradition for women to come back because it's thought that the uterus completely involutes at 6 weeks postpartum. But obviously, a woman's a lot more than just her uterus, and that's why that visit just so outdated and archaic that finally, I think last year the American College of Obstetricians and Gynecologists put forward a new guidance in terms of postpartum care that does recommend immediate follow-up within the first week to make sure that there is appropriate follow-up. It's still very much clinically driven. A lot of things are still very focused on checking blood pressures and everything, which I think addresses only part of the problem. But if we want to be dealing with all the issues that a new mom has to deal with, which also includes not just mental and behavioral health issues, but stress and sleep and nutrition and all those things, we really have to continue to broaden and enrich what we put into that postpartum care. But that's also where the current policy and financing doesn't support that at all, because it's all part of the global payment. And so providers have very little incentives and a lot of disincentives to do more during that visit. And so this is where what Congresswoman Underwood was championing in terms of extending Medicaid coverage for up to a year postpartum. That's really an important move in the right direction to providing better postpartum care.
Mm. Because currently they get cut off. A lot of women get cut off at 60 days. I mean, and not to mention the how inhumane this is, but I think to the questioner's point, I know that I struggled a lot in that immediate postpartum period. I mean, I've never been through something like this, right? Where you're totally focused on this other being who's up all the time. And I didn't know that lactation, maybe this is way too much information, but I'm just sharing that I didn't know that lactation and breastfeeding was so hard. And there are all these concerns that I didn't know where to go for help with this. And I'm a person of extreme privilege, and I'm a physician, and I have great health insurance, and I have a partner who's very supportive. And I just think about what other societal supports we can also build in. Yes, supports within the healthcare system and more frequent postpartum visits, but how great would it be? I mean, I went to visit a health center, actually a Planned Parenthood health center in California, where they care for people newborn to 100 plus, and actually encourage for new moms to bring their babies in for the same visit. So at the same time that this baby is getting a newborn visit and getting shots and screenings and everything else, that the mom is also getting her own screenings, because so often women forget to care for ourselves as we're caring for this other new human being. And I think we need to switch to more systems like that, more home visitors, community health educators, right, to your point, Dr. Liu, about other support systems. And I think that's where our country needs to go in really providing the care that women and families need.
I just wanted to add the bill that Dr. Liu mentioned that's trying to extend postpartum care for a year. This year has been an unprecedented year for legislation to be introduced or reintroduced. They actually called the group of these bills the Momnibus last May when a lot of them were introduced, because there are so many. And collectively, they really do provide the range of comprehensive health care that women need through this period of their lives. But they all take on a different sliver and slice. So collectively calling them the Momnibus and hopefully passing that through this year or in as soon as possible would be a huge, huge step in the right direction. We had 2 pieces of legislation that passed at the end of 2018 that have been really helpful, bills that have been worked on and we've campaigned for over a decade. So we hope that with this, again, additional information and political will and interest from the public, that we can move a little faster in the future.
Question down here.
So I'm Amanda with the Chick Mission. We help women with cancer preserve their fertility options. So I wanted to talk a little bit and ask your opinions on, infertility. I know it's the other end of the spectrum, but more and more women are dealing with infertility. And I know there is this biological clock, and it's real. And now with the improvement of science and egg preservation and things like that, actually I would ask you, Dr. Liu, just, sort of how can we educate women, if they're not scheduled for these regular visits because they're pregnant, how do the, I remember taking health class back in the day, but I didn't know anything about infertility and challenges there. So kind of, what can we do to incorporate that into the discussion?
Yeah, I think it goes back to what kind of Dr. Wen was saying in terms of having these like comprehensive, holistic kind of reproductive health services across the life course that really kind of start pretty early on. In terms of educating girls and women about their reproductive planning. When do they want to have a baby, whether they want to have a baby, and I think those things are currently done very poorly right now. So this is also assuring access to comprehensive health services across the life course. I think can be critically important, and that would include counseling about fertility and reproductive life planning.
Any other questions? Yep.
My name's Mika Standard. I'm with Children's National Hospital, and we are #1 in neonatal care. And one of the things that we are focusing on is maternal stress, in particular on the impact on the fetal brain, and then also after discharge, the impact of stress on kids and how babies thrive. And I'm just wondering, from that perspective, how are you partnering with pediatricians to ensure that both mom and baby are thriving under these intense conditions of, obviously, NICU, but then it's also stress just being a mom. But what are you doing to partner with pediatricians as well?
Or what do you observe happening?
So I'm glad you brought up stress, because I do think that we're really not going to move the needle on women's health, maternal and child health, without talking about the impact of chronic stress on women's health, and whether it's chronic stress from juggling multiple jobs, whether it's the chronic stress of enduring racism and sexism and violence against girls and women, and so forth. The American society puts so much stress on girls and women that I do think that it really has a big impact on their health. biologically, it's like if you keep like gunning the engine, sooner or later you're going to like wear out the engine, right? If you keep riding the brakes, sooner or later you're going to wear out the brakes. So if you keep your body on that constant fight or flight state, sooner or later you're going to wear out your health. And so this is actually a life course issue, and so that's where like you start like during pregnancy and when you're a baby and a toddler and a child and adolescent and young adult, and you make sure that we're doing everything we can to address the chronic stress. So I think there's now kind of greater recognition of kind of the impact of chronic stress on health. I think there's kind of greater recognition that healthcare providers have a role. I think we're still at a loss in terms of what to do, and that's just because over the last 20-30 years, we've gotten pretty good at telling women what they should do and what they should not do, but we still don't have a whole lot of tools in terms of kind of offering them, how do you cope with stress, both at the individual level, but how do you also build that interpersonal kind of resilience or community resilience in such a way that you build that community support to buffer against the impact of stress on health. So we talked about a number of things that our country should be doing. I think that's another kind of frontier. If we really want to move the needle on population health, especially for women's health, that's something that we got to do a lot better, both as a health system, but also in terms of addressing social conditions that create this kind of chronic stress that really impact on health.
Yeah, I think we can't let this conversation go without addressing the elephant in the room, that whatever we see as a choice is based on privilege. I mean, I was really fortunate in my pregnancy. I had a high-risk pregnancy the first time around. I never worried about would I lose my job if I went in for 24 hours of monitoring. Do I pay for this ultrasound or do I pay for food and rent for my family? I mean, I didn't have to worry about that. I didn't worry coming back to work. I was able to take 6 weeks of leave, which doesn't sound like a lot, but so many other people have to return back to work because they don't have any paid leave at all. I mean, I think there are a lot of societal policies that contribute to the stress. And I don't think our conversation about the individual factors, which are important to address, would be complete without addressing that part about the privilege and the haves and have-nots and how healthcare at the end of the day has to be considered right.
So we're out of time, but I want to end with just a quick word from each of you. Top of your wish list, near term, that would do something to address some of the issues that we've laid out here. If anybody jump in if you have one.
Language. That reproductive health care, women's health care need to be treated no differently from the health care that it is.
Yeah, and I would say education, the public preparedness for going through this life transformative process to set you up for success throughout the rest of your reproductive years.
We talked about a lot of things kind of during this conversation. It did just come up kind of at the end, so I just want to kind of call out social determinants. Let's make sure that we pay some attention to social determinants, including certain policies around maternity or parental leaves, around earned income tax credit, TANF, nutrition, food policies, all of those things to address the impact of social determinants on maternal child health.
Well, thank you so much to the panel for a fascinating conversation and you guys for your questions.